Okay, thank you very much, Tracy. Good afternoon, everybody, and welcome to the second annual general meeting of Staffordshire and Stoke-on-Trent Integrated Care Board. And just by means of introduction, I just wanted to remind people that integrated care systems exist to achieve four key aims. I'll just quickly run through those. Firstly, to improve outcomes in population health and healthcare. Secondly, to tackle inequalities in outcomes, experience, and access. Thirdly, to enhance productivity and value for money. And fourthly, to help the NHS support broader social and economic development. All NHS organisations must publish annual reports and accounts to allow scrutiny of the year's operations, finances, and outcomes. And this afternoon's AGM is an opportunity for you to hear about our achievements over the past year and the challenges we've faced, and to learn more about our future plans and priorities and how we're performing financially.
Anyone else could be pursued for possible.
I'm going to ask everybody in a moment, can I just make sure everybody's on mute? It'll just help with the sound quality. So anybody joining us, if you could just do that, that would be great. So just in terms of the meeting etiquette for today, what I'd ask is that all cameras could be off except for the chair and those presenting on the agenda. As I said a moment ago, please make sure your microphone's on mute during the meeting. It will make a real difference to the sound quality. Questions that have been submitted but via email in advance of the meeting will be picked up by myself during the question and answer session. And when we get there, please raise your hand on Teams if you'd like to ask a question when we get to that particular part of the agenda. Just on the slides, the next slide shows our leadership compact. At every meeting the ICB and ICS transacts, we present the leadership compact, and it's an important guide to the way that we conduct our business and the way that we behave as a system to each other, the public, and our partners. So the annual report and accounts will be presented in sections by members of the ICB executive team, and the agenda is laid out there on the screen now. The meeting will take around a couple of hours, and we're going to hand over now to Peter Axon, who will introduce members of the team who are going to take us through the first section. So Peter, can I hand over to you?
Yes, thank you, David. And firstly, well, good afternoon again to those that I saw at the board earlier, but good afternoon/evening to those that weren't there and are in the AGM. So great to be here. As David described, this is not our first AGM, so we're pretty well into our life as an ICB. And what I just wanted to briefly do in the couple of minutes that I've got to kind of introduce the team is unashamedly, really, to discuss a couple of slides that orientate around collaboration. So how we come together as a system to solve wicked, challenging issues, which I personally feel is the USP of all, the unique selling point, acronym up front, of all ICBs and ICSs right across the country. So, Jess, if you pop to the next slide, please. So just to, I suppose, recap to an extent, I think towards the start of the year that we're referring to here, we finalised what you can see in front of you, which is, we call it our strategy on a page, but essentially it describes who we are and what we're about in terms of our vision, our purpose and our mission statement, and interchangeable really between Integrated Care Board and the wider system, the Integrated Care System in that regard, because as you would imagine, much of what you see here, it heavily includes system partners. The leadership compact that David described a moment ago is the sandwich in the middle there, so the various terms that we've got in that leadership compact, and then you can see that the 5 Ps that are if you like, the bedrock of our integrated care partnership strategy. So a document signed off a couple of years ago now that underpins all that we do. Now, to an extent, that's all obvious stuff across that middle area. But of course, within each of those items, we've got, as all ICSs, frankly, across the country, some wicked challenges that we are dealing with. And it's important to say that those challenges, those opportunities are all underpinned by what we would expect in terms of our, we describe as enabling functions. So particularly, of course, quality on the bottom right-hand side of there. So just because they're at the bottom of the document doesn't mean that they're not as important, or actually the most important element of that whole slide. Okay, Jess, next slide. So again, a bit of a recap, but linking back to the year that we're referring, this again was evolving throughout that period of time. So we have our 3Ps operating model. So you can see the 3Ps in front of you there: portfolios, place and provider collaboratives. The bit that I'd pull out perhaps is, as you can see within the bubble that describes provider collaboratives, it also references system collaboratives, which essentially mean that collaboration across the system, yes, does very much happen at provider level, but also Integrated Care Board as a commissioner, and of course, not to forget the hugely important local authorities within the county are also relevant in that space. But essentially, those three bubbles and how they interrelate describe the journey that we go on when we look at services, maybe redesign services and implement those changes, which is through a planning process, a commissioning process, and then, of course, ultimately through to delivery, with the bottom right-hand side very much focusing on delivery of improvement and delivery of the day job. Portfolios very much focusing on planning and commissioning, and then where relevant, our two places, our Stoke-on-Trent and then our Staffordshire local authority footprints, utilising the opportunity that we have at that level, which of course is the interface with the local authorities, the Better Care Fund, that is a joint fund in each of those two areas, to again particularly work on that more detailed planning and commissioning phases of what we do. So essentially that is our operating model, and I'll describe, I think, on the next slide how that works in a bit more detail. So yeah, thank you, Jess. So the next slide describes those 7 portfolios that I mentioned in a moment ago. Now you'll read them and hopefully you'll kind of recognise the narrative, understand why we operate with these 7 areas. They're very much clinically orientated. They link heavily to flow, so that a patient's journey from taking urgent and emergency care, that initial phone call to an emergency facility, all the way through to post-discharge out of hospital, if that is the journey. So we try and capture patient journeys within each of these 7 areas. The one that I'd perhaps pick out that is vital going forward, or particularly vital going forward, given the move that we want to do far more of in Staffordshire, which is move from reactive to proactive and preventative care, is the one on the left. So improving population health. That I'm delighted to say the chief executive sponsors of that are, as you can see, Tim and Dave, who are themselves chief executives of district, borough, local authorities, which in itself I think is critical, in that the only way that call it the left shift of care and support away from reactive to proactive care, that the only way that we'll achieve that is to ensure that we've got a holistic approach to things with all system partners, critically local authorities, that includes districts and boroughs, and of course localities within the Stoke footprint. So a really important element of our operating model, that as an ICB and a system we very much orientate ourselves around, from particularly a planning and commissioning perspective. Jess, next slide. So I did mention I'd give some examples of collaboration, and you can see in front of you 5 there that we've had throughout a portion of last year and very much this year. And these system collaboratives focus fundamentally on challenges that we know we have, but on the flip side of that, fundamental opportunities that we know we're aware of. So demand management is a good example. Pick one out of the five randomly, but demand management fundamentally focuses on ensuring that the footfall in our urgent and emergency care portals is firstly minimised, so people don't need to attend A&E. But also, if they do end up in A&E, then the journey that they go on is as effective, efficient as it possibly can be for that individual and their family. So, and we know we've got an opportunity to improve in that area. And as I say, we've got opportunities in all five of those areas. But that's just an example of, I suppose, where we're trying to be as practical as we possibly can be in focusing our attention on improvement, and fundamentally at system level, so across a variety of partners, because all of the challenges essentially at this macro level are cross-system and relevant to multiple agencies. Next slide, please, Jess. So I did say unashamedly I would talk about collaboration throughout. So you can see some examples of awards, nominations that the system and system partners have been nominated for and have been successful within. I think the key point in all of these is that collaboration, working together, multi-agencies, working on opportunities is throughout this list. Now, I think it's really important to celebrate success, because actually when we've got really challenging times that the NHS, of course, has across the country, and we're not immune to that, it's important to take moments out and say, look, we are really successful at many, many things. So that's in part what this, of course, slide does. But it also describes, as I said a moment ago, the importance of working together in collaboration to solve those wicked challenges and problems that we've got. Next slide, Jess, please. And finally, I think it's really important to remember that collaborative leadership has to come from the top. So we as leaders, the senior management team across the NHS and social care within Staffordshire, have got a responsibility to do what we say, to act in a way that people that work across the organisations see us being collaborative, see that we are building trust across our partners, and see that we absolutely want to work together for the success of the NHS and social care system more generally. And wherever possible, we break down historically, legally created barriers to make sure that we fundamentally focus on the needs of the individual and of the population. So it has to start with us at board level, so that we can be seen to be that collaborative group of leaders. And a little quote there from Henry Ford that fundamentally says, you know, working together effectively is a sign of success. And it is a journey that we're on, but I think we've come a long, long way in the last couple of years. Okay, thank you. I think, Jess, that is my last slide. So I'm going to hand hopefully seamlessly over to Phil, who's going to take you through some of the operational stuff.
Thank you, Peter, and hello, everybody. So from a delivery perspective, 23-24 was a very challenging year, most definitely, but health and care partners really did come together to make some massive strides on our recovery journey following COVID-19, and also in terms of responding to continued demand and acuity growth, which we've continued to see. If we just move on the slide, Jess, if that's all right. Before I get into any detail, I just wanted up front to recognise, in terms of the context of any delivery conversation, the fundamental role that our emergency preparedness, resilience and response, or EPRR to their friends, teams have played in ensuring that we can continue to deliver care to our population despite any incidents or emergencies which have presented. There were several such occasions during 2023-24, but a really key example I wanted to draw out was the 13 periods of industrial action, during the year, which required complex multi-partner system planning to ensure that we're able to respond without any detrimental impact for our patients. In total, over the year, we had 41 days of industrial action, which, if you looked at it in the context of the year, is over 11% of the year consumed with responding to that alone. Our EPRR has been rated substantially compliant in 2023, which was a massive improvement compared to when we first did the assessment when the ICB was established, and our ability, I believe, both within the ICB and across partners, to manage response to incidents such as industrial action has been really, really strong and worth noting. From an urgent and emergency care perspective, in the 2.5 years I've been in the system, I've seen a great deal of change in terms of how partners work together to plan, execute and deliver plans as a health and care system. In 2023-24, a number of successes. I'll just reel a few of them off, but then give a bit of context. So ambulances have got to those in need quicker. We saw a 39% improvement in our category 2 response times for our whole population in the year compared to the year before. We saw a 4% improvement in 4-hour ED performance, almost 10% improvement in 12-hour within the department performance, up to 30% increase in virtual ward utilisation, a really, really key initiative that needs to get more and more important for us as we go through. As partners, we came together to establish an integrated discharge hub, which is a true partnership of agencies to ensure that people receive timely and appropriate discharge, which supports their independence and reablement from hospital. And also, our system control centre is now well established and embedded within the system and is key to managing flow across all portals 365 days a year. Despite all of that, we can't be complacent because we did not meet the national standard to ensure that we met category 2 response times within 30 minutes during the year, nor did we meet the 76% ED, but we did demonstrate continued improvement, and that improvement has continued into 24-25. And for example, in terms of that category 2 response time, we are now compliant with that. The focus on demand management and developing alternative pathways which promote care closer to home and avoid unnecessary escalation has developed during the 23-24 and more so into 24-25. And I think we've got some really exciting developments in that space, such as our new single point of access. If you can just move me on a slide, please, Jess, if that's all right. Thank you. Right, so winter is always a challenge. We now refer to it as surge because surges happen at all points of the year, not just in the winter months. So in terms of how we work to respond to that during the year, we recalibrated and utilised our single demand model that we have as a system and built all of our plans in partnership to cope with those times of surge. For the first time, we had a single system winter surge plan, which went through all of our partner boards, culminating in approval by the ICB board last November. The plan, as is demonstrated on screen, encompasses capacity, which is both direct and enabling, looks at workforce requirements and looks at risk management and ensuring that we're managing risk effectively. As is now traditional, we hold a learning event at the end of every year, reflecting back over how we've managed surge to look at what we've done, celebrate the success and carry forward the learning into future years. A few reflections from me in terms of that. Firstly, the leadership compact, which was on screen a little bit earlier, has remained absolutely central to our work. I think it's been upheld really well, even in very, very difficult operational times. It doesn't mean that everyone needs to agree on everything all of the time, but what it means is that relationships have matured to a point in the system where we're able to constructively and appropriately challenge one another during those periods of intense operational pressure. We've certainly improved in terms of how we manage, respond and de-escalate from periods of escalation. It's happened in a far more calm and structured way, I think, over the last year. And we've also more effectively shared our workforce in a flexible way to meet the system needs. So an example of that is the excellent work the People Hub did to support us in the middle of winter, facilitating mutual aid staffing into our community emergency response teams to support with closing staffing gaps that we had there. We saw some real success in terms of some innovative schemes during the year, such as Staffordshire Fire and Rescue Service, who responded to over 1,400 low-level falls within our system, and also supported over 900 patients with discharge from hospital and settling in back in their homes. So the learning carried forward really centres around continuing to evolve our use of business intelligence data to support the prediction and early warning of where we're heading into periods of surge, continuing to mature our approach to sharing clinical risk across the system, and also really ensuring that any initiatives we put in place have a return on investment in terms of outcomes and quality of care. Right, if we can just move through to the next one, please. If that's okay. Thank you, Jess. That's great. So, as mentioned at the start, waiting lists for procedures have increased nationally since the COVID-19 pandemic, and there is a huge focus around recovery back to pre-pandemic levels in terms of waiting times. So during the year, considerable progress was made with over 366,000 pathways closed during the year. I've looked back as far as I can in terms of data, and I can't find a year that for our population that many procedures has been carried out. So it's a real success in terms of that volume of activity. We've seen really strong progress in terms of our long waiters, 78-week waits during the year. We started with 589 and more being added each month, and got that down to 101 at year end. Similar progress around the 65-week waits, and that's again continued into this financial year. And in addition, to support management of demands, the ICB's work to help avoid unnecessary GP appointments by working with providers to enable direct access and self-referrals to various pathways. Just in terms of cancer, if we just move through to the next slide, please, Jess, if that's all right. Thank you. In terms of cancer, our absolute emphasis is on improving identification and survival rates. There's a couple of key metrics we're held to account on there: improving how quickly patients are diagnosed, and then improving how quickly those that are diagnosed begin their treatment. As a system, we achieved the 75% cancer diagnosis target within 28 days during the year, and we also made massive progress in terms of patients being treated within 62 days, and our backlogs, crucially for treatment, sustainably halved during the year. So I know, for example, at UHM, they entered the year with over 500 people awaiting, with a cancer diagnosis, awaiting treatment. That halved by the end of the year, and that's carried on into this financial year as well. As an ICB, we also led 15 campaigns to help people recognise the early symptoms of cancer and the importance of attending routine screening appointments. The other part of the elective pathway I just wanted to draw attention to is diagnostics, which is absolutely critical to elective and cancer pathway delivery. Nationally, as you will know, really, there's been a drive to increase diagnostic capacity through the provision of community diagnostic centres. 3 sites were identified for development across Staffordshire and Stoke-on-Trent, and 2 of those became operational during 23-24 at Cannock Chase and at Tamworth. And then we now have a site identified with work underway to operationalise Stoke in 2025. But in the meantime, we're providing that additional CDC capacity through different routes. So overall, in summary from me, before I hand over to Paul, some real tangible improvements in year from a delivery perspective, and I'm really pleased that the momentum in terms of those achievements has carried forwards into 24-25 as well. Thank you. And over to Paul EJ, I think.
Thank you, Phil. So all very seamless. I'm going to talk just for a few minutes. I'm losing my voice, so I'm not going to overdo the time. Everybody will be glad to know. Jess, could we go to the first slide? So just on this first slide, just to emphasise that the primary care priorities that we've had for this last year, or this current year, we've got 5 key priorities that you can see on the slide there. In essence, the main effort has been around modernising general practice and improving primary care access overall, with a sort of subtext of integration. So it's very much about that modernisation and improving access agenda. And you can see that reflected in those 5 key priorities that we've had for this last year. If we go on to the next slide, Jess, I just wanted to talk very briefly about some of the achievements within primary care. And I do mean within primary care. Sometimes we use general practice and primary care interchangeably. This is about primary care, so this is about general practice. It's also about pharmacy, optometry and dentistry as well. One of the things I wanted to highlight, which we sometimes overlook, is that the great bulk of consultations and patient interactions within the NHS happen in primary care. So in general practice this last year, we've seen 6.4 million appointments across our population. So that works out at roughly 6 appointments for each resident of Staffordshire Stoke-on-Trent. And what you can see there in the top left is that's a 7% increase on the year before. So primary care is providing probably around 90% of the activity in the interactions with our population. It absorbs about 10% of the budget overall in terms of what it uses. So it's a very efficient, very productive service that we have there. And I'll talk in a little bit, go on when I go to the next slide, talk a little bit about satisfaction within there. I also wanted to highlight down in the bottom left the practice-friendly schemes that we have in place. We've got 422 now across our 145 practices, and there's all sorts of different things. There's dementia-friendly, the daffodil standards, veteran-friendly, safe surgeries, all sorts of different initiatives that our practices and primary care networks pick up, drive forward. Veteran friendly, for instance, we are the best performing in the West Midlands. I think we're up at nearly 90% of our practices now as veteran friendly in terms of the access there. I think in the middle bottom, just highlighting that 82% of people with learning disabilities had their annual health check done. That's over 5,000 people, and it's more than were done the previous year. I can never forget my public health roots, and I'm always interested in turning that round and working with Heather and others about who are the 18% that haven't had their annual health check done. So it's that drive forward, but we are improving. We're getting more and more done there. And then I want to just highlight on the right-hand side 2 points there. One is that we have engaged and worked with our local medical committees regularly. You may recall that about a year ago, the LMCs wrote a letter expressing no confidence in the primary care team and the ICB. And we've worked really hard with our local medical committee around that, making sure that GP voice is listened to, making sure that we co-produce with GPs and involve them in the primary care transformation. And I think we've made great strides over this last year on that. There's always more that we can do. We'll continue to work on that. But I think we have moved considerably over this last year in terms of that relationship there. And then I think bottom right, which I do want to highlight in terms of thanks to my team and others within the ICB, in that we safely, effectively commissioned a caretaker to run the Gordon Street practice in Burton. It sounds very simple, it's very complex in terms of making sure that we get a safe transition from one provider to another. And again, I want to do a big shout out to the East Staffordshire Primary Care Partnership, who've taken on that caretaker role and really worked very, very hard to deliver a really good service to the Gordon Street practice. So I think, can we go on to the next slide now, Jess, please? And talk here a little bit about, it's entitled General Practice Patient Satisfaction. It's actually more than that, as you'll see in a minute as we go through it. And I wanted to highlight some points here. And the patient satisfaction survey that's done every year, done across the country, so it allows us to benchmark to the West Midlands, it allows us to benchmark nationally. And I've picked out some indicators here. And you can see top left, 76.3% were saying their overall experience was good or better than good, which is higher than the national average. Over 90% saying that their needs were met at the last appointment. These are really, really good statistics in terms of that. Below that, 81% of the appointments took place within 2 weeks from first contact, which again is higher than the national average. Again, we should be asking the question of, could we do better than that? What were the 19% that weren't seen within 2 weeks? How might we make a change to that? But I also want to highlight that it's starting to pick up in that national survey around pharmacy services, optometry and dental. And you'll see down on the right-hand side, around 89% were saying that they had a good overall experience of using pharmacy services. And 73.5% reported good overall experience of the NHS dental services locally, which is 4 or 5 points higher than the national average. So I think just some points there just to show that. And one that isn't on there is the access of patients to their online records. And we now have 95% of our practices offering online access to our patients, which is the highest in the West Midlands and one of the highest in the country. Just finally on this, just want to highlight two practices. One practice, Featherstone, that was written to by Claire Fuller earlier in the year as having been in the excellent group overall on the general practice survey. And also we wrote to not only to Featherstone on a national basis, but also to Betley and Abbots Bromley, who were recognised by us because they were in the top 10 GP practices in the Midlands for their patient experience in the survey. So we have got some really, really shining examples of absolute excellent practice across primary care. So we'll go on to the next slide, please, Jess. This is just to highlight the fact that over this year, we have now taken on the delegation of pharmacy, optometry and dentistry to the local ICB. We do this still in conjunction with the regional office, and we do a lot of this work through the collectively through the Office of the West Midlands. So to highlight really those three things around developing a local dental plan, and I talked about that at the board meeting earlier, where we now have a West Midlands dental recovery plan. We're developing a local plan around that based on a health equity audit that's been done for us, and we'll be bringing that back to the ICB board in January next year. Optometry, we're starting to work more and more with optometry and understanding how we can really start to influence how that is part of our primary care offer and that integrated primary care offer. And of course, over this last year, we've seen the introduction of Pharmacy First, and we're working really, really hard to try to maximise the benefit that we can get for patients and residents from Pharmacy First, and those 7 conditions that they can go direct to the pharmacy to get a prescription without needing to go and see their GP, and so on. So, Chair, I think I'm going to stop at that point, I think. And I'm now handing on the baton, and I've forgotten who I'm handing on to. I'm handing on to the other Paul Brown. So thank you.
Thanks, Paul. So I'm just here to present the financial position for the year, and pleased to say that we had unqualified opinion from our external auditors, and in fact the accounts process went really smoothly this year. So I'd like to put on record thanks to Dave Skelton and his team. Dave's our financial controller. This first slide just summarises for you the position in terms of how we spend our money. So the allocation for the ICB was 2.7 billion. As you can see from the chart, the blue bit, over half of that goes into local providers. Paul mentioned primary care there as probably the next big bit after the spend with other independent sector providers that we use to provide care for our population. Our local providers also get income from other sources, so in total we spent as a system 3.6 billion on the healthcare for our population. This next slide summarises the position in terms of the targets that we have. We have 5 financial targets. We managed to meet 4 of those. So we had the management cost target. It's been increasingly difficult as an ICB to meet this, but we've done it. We have had a reducing management cost, and we support that because we want to put every penny that we can into patient care, but it does put the pressure on our teams. But we met the ask, and we met the management cost target. We managed our cash, and we lived within the cash balances that we were allocated. We paid our suppliers quickly, over 95% of them within the mandated 30 days. And we also very supportive of the mental health investment standard, which is a standard which was brought in a few years back to ensure that proportionately more money is put into mental health to improve mental health provision, and we met that as well. Unfortunately, we did not meet our revenue resource limit. We overreached the allocation or the target by 91 million, as shown there. This next slide summarises a bit of the history for those of you on the call who have been around will, I'm sure, remember this, that the Staffordshire system has been a system with quite a lot of financial challenges for quite a long time, and that over the period of the CCGs accumulated to just under 300 million. Financially, the COVID years were a period of respite in the sense that there was greater allocations, and we were able to post balanced financial positions across the system in those 2 years. And then, as I say, unfortunately, in 23-24, the year that we're reporting on here, we did post a deficit. So the point of this slide is that there are some fairly structural issues with the costs of our health system that we're working on together as a system. And this next slide just talks a bit about how we're looking to do that. So in terms of the current year, we do have a recovery plan in place, a financial recovery plan in place, and those who attended the board will have heard a bit about that earlier. It is an extremely challenging position. It is so nationally. I think all systems are struggling because of the demand for services and the cost pressures that is generating. But you know, we're working, and this comes through from the previous speakers, from Phil and from Paul. We are working very much as a system to look collectively about how we utilise the collective resource that we have to ensure that we maximise the health benefit we're able to deliver within that. And although we are seeing these financial challenges, we are nevertheless optimistic about our ability collectively to work our way through that. And the way we're going to do that in terms of our approach, it is really a focus on patients and the patient pathway. Our fundamental belief is that the best care, the most efficient provision of care, results in the best financial outcome. So it's very much a clinically led recovery process. One key focus of that is on CHC, continuing healthcare, and in a minute you can hear from Claire Underwood, who's driving a really impressive programme to improve the care that we provide to that cohort of people. but that is also delivering financial benefit. And that really is the central philosophy of what we're trying to do, is provide better healthcare. And when you provide better healthcare, you achieve better financial results. Inherent in all of this is workforce, where most of our money does go on paying people, either directly from the ICB, but more into our providers who employ people. We're a people business, and so working with our teams on delivering financial improvement is what we're doing. And so that I'll hand over to Gemma, who's going to talk a bit about workforce.
Thanks, Paul. Good afternoon, everyone. I'm Gemma, trainer head of the ICS people function and representing Nish Irvine, the CPO, who's out this week. So I'll take us through the people, culture and inclusion. The first slide just sets out our context that we're working in at the moment, and colleagues have described some of that already. Nationally, we've got the NHS long-term workforce plan, which has now been complemented by the Skills for Care workforce strategy. And both closely align and describe how we should train, retain and reform our workforce. And then overlaid on top of that, more recently, we've got the Lord Darcy report, which sets out several recommendations around workforce, including workforce planning, staff engagement, inclusion, collaboration and digital. In terms of locally, our workforce continues to face everyday challenges and increased pressures, as we've heard, but yet respond with that commitment, dedication and passion for the care and treatment that they deliver to our local population. So with all of that, we need to strike a balance in the context of building our future pipeline, increasing retention and well-being of our current workforce against improving productivity and the financial position. Next slide, please, Jess. So this next slide just depicts our current workforce position, and it's based on the most recent data set. So our workforce has grown, and we're investigating its links to our activity and financial position, as Paul's mentioned. Turnover has decreased, which is positive, and consistently, and so too have vacancies. Our agency usage is steadily reducing, which is a really good news story, and trusts are working really hard to continue reducing reliance and spend. We are using bank, and this is positive in terms of the cost and flexibility, but we're investigating how we can work better to reduce the dependency. And then finally, sickness rates have steadily increased, and we've seen that over the past year and more recently, and we're working in partnership with trusts and our wider partners, actually, as part of our employee health and wellbeing work stream and programmes of activity. Next slide, please, Jess. This next slide is a summary of our 2023-24 annual report and the achievements across our people, culture and inclusion programmes. And you'll see from that there's a lot of detail in there, but and in the report itself, we've achieved so much as a system. From a people, culture, inclusion perspective, we've been working together for some years now on programmes from a workforce perspective with ICB, NHS Trust, social care, primary care, local authority, voluntary and education sector partners to respond to those risks and those challenges that we face, but improve the experience of our workforce. And within this, I think, particularly from a widening participation and access perspective to jobs, our inclusion agenda, wellbeing, retention, leadership perspective, we have seen real improvement. And then more recently, how we've engaged with our local communities. So just a few highlights that I'll pick out from that slide include our system apprenticeship programme, which has been running for around 5 years now, and we've got 58 apprentices on various health and care courses over the last year. And working with partners to build that programme has been the key to success. We were awarded the National T-Levels pilot, working in partnership with Department for Education, and we've gained recent recognition for our work as an exemplar system in our approach. Wellbeing and retention, and I've mentioned that a few times, that is key to us, but it has improved through the work of the retention programme, which adopted the principles of the National Retention Programme, our system staff psychological wellbeing hub, which has been hugely successful, and then the occupational health service and the contract that we hold across NHS Trust. And then finally, our focus on the equality, diversity and inclusion agenda has continued in earnest with the System Inclusion School and reciprocal mentoring programmes, just to name a few. Next slide, please, Jess. Then just moving on to this next slide, which illustrates our journey to work approach and the way in which we work with system partners, our workforce and local communities from a people perspective. This just encapsulates how our ethos of working, outlines how we will widen access to jobs and careers in health and care, how we look after our people in work and help them develop, grow and stay with us, which is really important to us. We start in primary schools with engagement at a really young age through to university, and the journey sets out how we're working with those young people and educational institutes to promote careers and build that future pipeline. And then on to how we develop and work with our people in work, supporting health and wellbeing so that they stay well and working in Staffordshire and Stoke-on-Trent health and care system. And then with that golden thread throughout of our approach to leadership, culture and inclusion across the system. And then all of this aligns, as David and Peter mentioned earlier, to our ICB aims overall. And in particular, just to note examples of us working with children, young peoples and population health portfolios to align the work that we're doing. There is a video that we'll share in the chat now, which describes this approach a little bit more eloquently than me, but please do have a look at that video because it does showcase the work that the system partners have been doing. And then just the final slide, please, Jess, just to run through our current and future programme focus. There's a list there of things, and there will be things that we've missed off. You know, there's lots of work to do from a people perspective and to deliver the people agenda and the challenges that we're facing in our system over the next year, but it will focus on some core areas under the umbrella of that journey to work model. So enabling delivery of the medium-term plan that's been mentioned from a workforce perspective, developing productivity improvement initiatives involving and engaging our workforce in that work. We'll continue to work with partners on workforce transformation, so working differently, designing new roles and further utilising technology and digital solutions. Education, training and development will continue to be a big focus for us, further strengthening relationships with our education institutes, developing new courses and securing that future student pipeline. And then in addition to that journey to work model I've described, we're going to focus more on our approach to the journey in work for individuals. So how are we enabling movement across our system and retaining people within Staffordshire and Stoke and developing them and delivering those core aims. We're going to build on our anchor employer model across the system, which involves improving our workforce health and wellbeing as residents of Staffordshire and Stoke, working in partnership with our population to improve employment rates, supporting access into those health and care jobs, focus on inclusion and representing our local population in our workforce, which again all supports our ICB aims around population health and economic and social growth. All of this is going to be underpinned by our system organisational development plan. And key to that is the partnership working towards our shared purpose. So I will hand over at that point to Heather to cover quality and safety.
Thank you very much, Gemma. Good afternoon, everybody. For anybody who doesn't know me, I'm Heather Johnson, Chief Nursing and Therapies Officer, and I'm just going to give a really quick run through some of the activity I've undertaken in relation to quality and safety of patient care. So if we could have the next slide, please, Jess. So this slide is a snapshot of a really important development for the ICB. So this year we finally approved our quality and safety strategy, which is a really important document in terms of all the work we undertake from a quality and safety point of view. As you might imagine, it's quite a hefty document and much bigger than this strategy on a page that we've tried to illustrate here. But what we've captured is all of the key areas that I'm going to talk a little bit more about as I move through the presentation. I think there's a couple of really important points. One of those is that, as you might expect, and you may have noticed if you've looked to the right of the yellow boxes, we have quality and safety as our golden thread. And I always listen intently to conversations and presentations to make sure that it's not just me that's mentioning quality and patient safety. And of course, as you've listened today, you will have heard that it absolutely wasn't. Everybody has made direct reference to the importance that we place on the quality and safety of services provided in our local area. So for each of these quality outcomes that are listed on this presentation, I've got an additional slide with just a few examples, and it would be impossible to go through all of the examples, and anybody who comes regularly to board or any of our other meetings will see that we've talked about some of these in much more detail, but I wanted to try and give some detailed examples of the kind of things that we do. I want to start with a bit of a health warning, really, to say that some of the things I list may feel very NHS orientated. That's a consequence of the fact that we as NHS employees and authors think very NHS, but actually what we are doing and actively doing is working really, really closely in that collaborative and supportive approach that's been described earlier in the presentations, and completely acknowledge that we cannot do what we need to do, excuse me, without the partnership and support of our social care and independent sector providers and the wider system. So I just wanted to make that really important point. So if we could go on to the next slide, please. So this is in relation to lived experience. So what we're trying to do is make sure that people who are really experiencing the services that we provide and or commission in the system are contributing to the work that we do in respect of quality and safety. And there's a few just brief examples on this slide here, but actually some of these are some of the really key developments that we've seen over the last couple of years. So LEADER, which I think most people are aware of, relates to the learning from the lives and deaths of people with learning disabilities, is exactly what it says there, learning disability mortality reviews. And we actively work with members of the individual's family after that person's unfortunately passed away to make sure that they're given an opportunity to share what it was like in terms of their experience of the care that their family member experienced during their time in care. And that's really, really essential to making sure that those review reports are comprehensive and really do consider and learn from things that have gone before. As I said, I'm not going to go through all of these, but the bottom one on that list is the MNVP. And I know we use a lot of abbreviations in the NHS, and I apologise for that, but I've expanded that there. So the Maternity and Neonatal Voices Partnership, again, a very topical subject at the moment. Maternity is really, really high profile, and quite rightly so, because if it's not safe, we need to know so that we can address it. And one of the biggest pieces of work we do on maternity at the moment is our work with the Maternity and Neonatal Voices Partnership, which is where we bring in maternity champions, so people who've used services to make sure that they're given a direct opportunity to feed in and feed back on what their experience was, and we can take that and learn. Whether that's a good experience, whether it's a bad experience, we can take it and learn. And we're actively working at the moment to expand the involvement of some of the harder to reach groups in that area. So if I could have the next slide, please. And so the next slide is promotion of it shouldn't actually say self-care there, it should say safe care. I'm the first one to spot my own typo, and I'm always the one that picks up everybody else's, so I do apologize if that is incorrect, but it is about safe care, and that fits with the indicators that we've included as examples. There's lots and lots and lots of activity goes on to ensure that safe care is both commissioned and provided across the system, and we do numerous activities to make sure that when changes are made, nothing happens that will have a negative impact on patient care. And if it is going to happen and there is a potential for negative impact, that we actually identify that and respond to it. And an example there is the improved quality impact assessment process that we've got, which now enables us to very quickly but very confidently check when a service change is being made, what the impact will be on patients who are using the services. And that can be anything from how long will it take for somebody to travel to a service if we're moving it, to what is the volume of patients that would have been using that service, and will that number rise or fall as a consequence of a change. So they're just, again, some examples. If I could have the next slide, please, Jess. Thank you. So staff are most valuable asset, and I say that without any apology at all. we've absolutely got to take, as part of that strategy, a big responsibility for improving staff experience. And of course, by improving staff experience, we are actively working to promote a culture of transparency and shared learning, and making sure that we learn from every opportunity where somebody picks something up, somebody identifies something that's wrong. What's happened in the last 12 months is the implementation of what we now call PSIRF, and that stands for the Patient Safety Incident Response Framework, which is a replacement for serious incident monitoring and management. And again, we're working very, very closely with staff to make sure that they're given an opportunity to contribute to learning from every incident that they've been involved in, so that we as a system can not only ensure that staff remain happy, but also can maximise the learning. Similarly, through the work of the safeguarding team who are under my directorate, there's always an opportunity to learn from safeguarding cases involving both children, our most vulnerable people, but also our most vulnerable adults. And again, making sure that staff are able to contribute to, and we listen to those as part of those learning reviews, is a really essential part of making sure that staff feel valued as part of our teams. If I could have the next slide, please. Thank you. So the shared approach to quality, and I suppose I've touched on this a little bit before. I've apologised for making this quite NHS focused, but at the same time acknowledge that we do work as a system. And some examples of some of the things that we've done as a system are included in this list. So the new approach to the Patient Safety Incident Response Framework, the PSIRF that we referred to on the previous slide, and all the associated learning, is a really good demonstrator of how we work together. And of course, learning from patient safety incidents doesn't just apply to the NHS, it applies to every single partner. So for example, if a patient was admitted from a nursing home into a hospital and something happened during that patient journey, we need to maximise our opportunities to learn so that we can build safe services for the future. If I could have the next slide, please. Thank you. I promise I've nearly finished. The other thing that we're working really, really hard on is fair and equitable services for all. So Quality Committee have taken on the responsibility for oversight of the ICB responsibility for reducing inequalities. And we see that as a really key part of our work, but also as part of the collaborative working that we've described throughout these presentations today. And of course, embracing the diverse makeup of our population is a really, really key part of our work, because one size doesn't fit all, and we know that, and we need to absolutely take every opportunity we can to fully benefit every single patient that's using our services. And then my final slide that links back to the quality strategy is around continuous quality improvement through research and evidence-based care. So as I've said already, we are always learning from incidents, learning from patient feedback, learning from anything that brings us complaints, for example, anything that brings us a descriptor of what our patients have experienced. But at the same time, we're also looking to the future. So we are currently working to implement the Chief Nursing Officer's research strategy, for example, and that's about giving more nurses and allied health professionals access to, but a responsibility for undertaking research to ensure that development of nursing excellence continues, and that continuous quality improvement is a core part of our activity. I think just in summary to say, I'm conscious it was a very quick canter through what's quite a big document. It'd be impossible to list everything we do, but I hope that this brief summary highlights to all of you the importance that we collectively place on quality and safety for the population of Staffordshire and Stoke-on-Trent. Thank you, and I believe I'm handing over to Claire.
Hand over to me for a second.
Handing over to the chair. I beg your pardon. Thank you.
Thanks very much to Peter and the team for taking us through that presentation. A lot of detail there, necessary detail that's available in the annual report. But Heather's presentation there actually dovetails quite nicely into the next segment, which is a case study about continuing healthcare. And everything that's been said is about what it feels like if you are the end user. What's it like to actually be a patient on the end of these services and the statistics that we've presented to you this evening? So I'm going to hand over now to Claire Underwood, the Director of Nursing for All Age Continuing Care, and Paul Garner, the Transformation Clinical Lead for Palliative and End of Life Care, just to take us through a very short case study, but one that demonstrates what it's like for patients who are coming to the end of their lives. So if I could hand over to Claire and Paul.
Thank you very much, David. So thank you for the introduction. So as David said, my name is Claire Underwood and I'm privileged to work here in the Integrated Care Board as Director of Nursing for All Age Continuing Care, under the leadership of Heather, who you've just heard from. In my work every day and in our work as a team, we strive to uphold the values of the Leadership Compact, and we take those very seriously. And also my personal strategy that I've held for 33 years of working in the NHS of, if it's not good enough for me or my loved ones, then it isn't good enough. And we're delighted to empower colleagues to be able to do the very same. As Paul Brown has already mentioned, we've been on a busy and exciting journey in the last 12 months that has seen many quality improvements, and these have enabled better experience and outcomes for our population in line with the quality strategy that Heather's alluded to, and the themes of the system strategy that was shared earlier by Peter and the rest of the team. We are privileged in all age continuing care to work with individuals from birth to end of life, and the patient story that we have the honour to share with you today on behalf of the team is one of a patient at the end of their life. So I do hope that it's not too uncomfortable for individuals to hear. Partnership, personalisation and collaboration are at the very core of all of our work and of this story that we're sharing today. And without this, we wouldn't have seen the improvement in experience that we have. It's involved acute trust colleagues, care home colleagues, local authority colleagues and community trust and primary care as well. Next slide, please. Continuing healthcare forms part of the portfolio that is known as all age continuing care. It enables care for individuals who are over 18 years old who've been assessed as having a primary health need. This then means that they are entitled to healthcare funding to support those needs. It also includes care for individuals who are approaching end of life, and this is nationally known as fast track care, and more affectionately referred to within Staffordshire and Stoke-on-Trent as end of life care. Such care helps people to be cared for in their own homes or in a care home, depending on their preferred place of care and death. The Palliative Care Coordination Centre took over the coordination of end-of-life care in December 2023. Prior to this, we saw many unnecessary hospital admissions, unnecessary expected deaths in hospital, and longer waits for care home, hospice or home discharges for end-of-life patients. So the Palliative Care Coordination Centre develop and lead this care now, liaising with all colleagues involved in an individual's care and most importantly with the patient and their loved and important ones. It enables right care at the right time in the right place with proactive and compassionate coordinated case monitoring, supporting patients' families alongside their individualised and personalised needs. It supports safe discharge from hospital and reduces undesired and unnecessary admissions to hospital, and it allows individuals to improve and step down off the pathway if it is the right thing to do. So I'm going to hand over to Paul Garner, my colleague now, just to share the story. Thank you.
Thank you. If we could have the next slide, please. So, I mean, this is a story about a 78-year-old person. They suffered with dementia and heart problems, and they've been in and out of hospital several times at the beginning of this year with a background of general deterioration. On their last admission, one of the doctors looking after them had conversations with them and their family and decided that end-of-life care was appropriate for them and that we should focus on comfort rather than unnecessary active treatments. The mechanism for providing this care is the end-of-life home care pathway. As soon as the referral was sent over, conversations started with the patient and their family. A care home was identified that they were happy, they suggested it, and it was appropriate for their needs. A place was arranged and they were able to be transferred into their new home the next morning. The pathway means that this is the beginning of a process. It's not the end of it. The conversation keeps going. We stay in regular contact with the person and their family to make sure everything's in place and they feel supported. If they are with us for long enough, we start to visit them first with healthcare support workers who can build a relationship with them, and then with our nurses. The aim is to ensure that they receive safe and high quality care, the right care at the right time in the right way. I'd like to share some feedback now. If we could show the next slide, please. I think we started this process a couple of years ago and it's developed, and it sort of came into its current form at the end of last year. And I think we were motivated to make it better. We've all worked in end-of-life care for a long time. And I think this compliment, which was received by the team, sums up what we hope to achieve when we set out to do it. It represents the journey that we go on with people, and it also represents the contribution of everyone that comes along that with us. So that's NHS staff in care homes, and also domiciliary care, because we work with those providers as well. And it just made me, it came at the end of a really bad week, and I think it made such a difference to us, and it gave us such a lift, and I'm really proud to share it with you today.
Thanks, Paul. Next slide, please. So what does this work actually mean? And around the patient stories, it makes best and efficient use of appropriate resource. It improves experience, reduces pain and discomfort for individuals, allows people to achieve an end of life that they would and may wish for, no matter how difficult that is. It enables us to provide better advanced care planning, and makes this more likely to happen, prevents unnecessary attendances or admissions to hospital. The story that Paul shared, we know this individual did have 2 admissions to hospital, one of which we feel was unnecessary, so we know that there's still more to do. It enables us to support families through grieving and that bereavement process at the time that that's identified, gives choice and control to individuals and their loved ones, enables improved comfort and symptom management, supports person-centred decision making and personalised care, and allows access to experts in end of life and palliative care for patients and their loved ones. As we've said, there's still more to do in some cases to prevent admissions and ensuring timely response to diagnosis. So it is a journey that we're on. We know we're not perfect yet, but we're really proud of what's been achieved and delivered. And hopefully the demonstration of the service that this has accessed and that Paul's here today from those community services is demonstration of how we are working in partnership and collaboration with one another, in support of the best interests of the population that we're serving. I've now finished. If the story that we've shared has affected anyone in any way, or anything that Paul and I have shared, please do get in touch and we will look to enable support for you, and thank you for listening to our story.
Thank you very much, Claire. Thanks, Paul. Really brings to life, doesn't it, why we're all here and what we're trying to achieve for our communities and citizens. We're going to move now, if we can, into the looking forward section of the AGM, and I'm going to introduce Nikki Harkness, Paul Edmondson-Jones and Lynn Miller. Nikki, I'd be grateful if you would start the presentation, then hand over to Paul and Lynn, and then back to me, Lynn.
Thank you. Thanks, David. And hi, everyone. My name is Nikki Harkness. I'm the Provider Collaborative Programme Director for the ICS for the system. I'm here today representing the Chief Transformation Officer, Elizabeth Disney, who unfortunately couldn't be here today. I'm going to take you through the next steps really regarding the development of our operating model. So if we can just move on to the next slide, please. I'm going to loop back a little bit to Peter's earlier presentation around the system operating model. And I think what Peter described is the structures that we've put in place in our system to ensure we effectively work collaboratively together. And this really is just about the next steps now around our developing a system operating model. As we said, we've already established our portfolios and our 7 portfolios, and some of the things you've heard today are actually driven and developed within our portfolios that we've set up. Our portfolios have a wide range of partners around the table, not just from NHS bodies, but also from our local authority. We have patient representatives there, and we certainly have the third sector there as well, to align our plans and agree the actions we'll take together to either change things immediately and redesign things, or to think about the transformational change that we need to do in each of those portfolio areas. So a lot of work that we've done over the last 12 months is around planning and supporting the delivery of those priorities through each of the portfolios. And there's some examples there around some of the things that we've done, and as you've already heard in the presentation. The provider collaborative programme, I think, has been established over the last 18 months. But prior to that, I think I'm always really keen to share that providers have collaborated for many years, either informally or formally, particularly around services that are either fragile for various reasons. Could be workforce, it could be any other form of resource, where we need to come together and actually do that work. What the Provider Collaborative Programme has done in the system is pulled all that together so that we understand the different types of collaborations that we've got, both in system and out of system, and then also look to use the programme to actually start to develop system collaboratives, which are against our priority areas that we have. And I know you heard about those earlier on today, so I'm not going to touch on those. But I think it's important to note that we have got different types and different forms of arrangements, both in our system, but we also collaborate out of our system. And we have some good examples of that, both in the acute collaborations with Shropshire and also with Cheshire. And from a mental health service provision perspective, certainly within the West Midlands, we have lead provider arrangements that our Trust MPFT and Combined Healthcare are part of that and are actually leading some of those specific pathway areas. So I guess I'm trying to sort of share with you really that we have made such a lot of progress, and we've built on those sort of pieces of work that were already there and evolving within our system. But there's still an awful lot to do. This year, the portfolios and the Provider Collaborative will remain key parts to our operating model, and we'll continue to support their ongoing development as the key vehicles for transformational change and service redesign and delivery. So you'll hear much more about those next year as well in next year's AGM. Can I move us on to the next slide, please? So the third part of the operating model is place, and what we've done over the last 12 months with regards to place is start to build a strong partnership approach, both in Staffordshire and Stoke, which are our 2 places. Over the next 12 months, we're looking to support the ongoing development of that model and build the function of our joint commissioning boards as key delivery vehicles to commission services through place. Throughout the next 12 months, we will develop the delivery arms of those places and link to the broader partners at area, locality and neighbourhood levels. And both Paul and Lynn will take you through those emerging partnerships, which again have built on what was previously there. So we're not trying to reinvent the wheel. What we're trying to do is align and pull together and collaborate. Our key areas of transformation, both at place level and within our portfolios, will focus on community services across our geography and ensure that we focus on bringing care closer to home, care that's proactive and preventative, and care that is digitally enabled. And part of that will be to ensure that we do that with partners, as I've described before, through our portfolios and through place, ensuring that we engage with everyone, both from a local authority, NHS provider, third sector, and patient perspective. We're going to be looking to develop our core offer for our frail population, including reactive care for severe frailty and proactive care for moderate frailty and preventative care for mild frailty. And what we're doing is going to build on some of the work that's already been developed within the end-of-life long-term conditions and frailty portfolio, where we've done a few tests of change and pieces of work to look at what are the sorts of models that we could have in our system and what would the core offer be. So very much building on that work and looking to scale up through place and through provider collaboration. We'll use our delivery teams to do that at sub-place level to deliver new services. So that's the ambition for this year for place. But also, as I've described, I think it's important to note that we build on all of the things that we've already got in place and have already developed, and those partnerships that are already there in the neighbourhoods, in the localities, and within our place arrangements to enable us to do that. I'm going to hand you over now to Paul and Lynn for the next two sets of slides. Thank you.
Thank you very much. Thank you, Nikki. So I'm going to take this first slide and then I'm going to hand over to Lynn to take us through the rest of it. So I just want to, we're going to talk a little bit about an update on the Integrated Care Partnership. Just to remind us that the Integrated Care Partnership is a statutory committee. It brings together that broad set of system partners that we've all talked about throughout these presentations. It includes local government, both upper tier and lower tier local government. It includes the voluntary community and social enterprise sector, NHS organisations and others. And we've got what I think is quite a dynamic and good integrated care partnership. The meetings are co-chaired by David as the chair of the ICB, and also by the two leaders of the local authorities, the upper tier local authorities, Staffordshire and Stoke-on-Trent, and they take it in turns to chair those meetings, which I think shows the strength of that partnership. The key role of the ICP was to develop a health and care strategy for the area, the ICP strategy that we have, and the aim of that was to address the four key aims of the ICB and the ICP that David talked about at the beginning. And there's a slide here that just shows the complexity of the sort of architecture, the system architecture we're working in. You'll recall the tree from the very start of the ICB and the ICP. We've used this tree as an example of everything that's included within there. And just highlighting at the bottom there, we very much as the ICP look to underpin the work that everybody else is doing. We've talked about the fact that what we want to do is to make the overall impact greater than the sum of the parts, and we've got lots of parts here. So how do we make that overall impact greater? We work with two health and wellbeing boards at the upper tier level, and two health and wellbeing board strategies. We've got, of course, at district and borough council level, they also have their health and wellbeing strategies. We've got two, again, upper tier overview and scrutiny committees. We also work with the overview and scrutiny committees of the lower tier borough and district councils. We've got two Health Watch partners. We've got two voluntary sector association partners, and then we've got our Health and Care Senate. So we've got an awful lot of that architecture to work with and make sense of. So that's really just to sort of set that scene about what are we trying to work with. And I'm going to hand over to Lynn now to talk a little bit about what we've done and where the ICP is going over the next year or two. So Lynn, can I hand over to you now?
Yes, please, Paul. Hello, everybody. My name is Lynn Miller. I'm the Portfolio Director for Improving Population Health. So if you could just go to the next slide, please. So as a health service, we can only really influence 20% of the population's health by treatment largely. We know that most people's health is influenced by the wider determinants. So, for example, the homes that people live, the work that they do, the lifestyle choices that we make. So really, if we're going to make a difference to the health of the population, we need to think very differently. We need to think beyond treating body parts, arms, legs. Think about the person holistically through their life course and the places that they live, the communities they live in, and the choices they make. And to do that, we need to work very closely with our partners, particularly in local authorities in the BCSE sector, and maximise the offer that we all give collectively to improve people's health. So Peter at the beginning touched on the 5 Ps. I'll give you an example of how we are tackling those Ps and adopting that approach into everything that we do, but a real example of at scale prevention that we've adopted that approach, but also describe the 6th P, which is really important to my portfolio, but also how we influence planning over the next 5 to 10 years through population health management. So what that is very much a data-driven approach to understanding the health needs of the population. And really, it's about moving from a reactive health system, which is where we sit now, into a more proactive service offer where we target ill health and we put mechanisms and interventions in place to keep people well for longer. You probably heard around the Lord Darcy investigation into the state of the health service and the recommendations that came out of that we have to focus on working with our places, working differently, and prevention is absolutely key to that. So I think we'll hear more about that in the new government's health mission as that starts to come out over the next few months. So just to describe the 5 Ps, if you like, at the heart, we've developed these Ps with our engagement through the Integrated Care Partnership Strategy. So these were the words that stakeholders, that our partners told us about what was important to them. The first being people and communities, and I'll describe how we're working at a small place level to really make a difference. We are a big strategic organisation. We need to reach out and harness the energy that's in our communities with our community and faith leaders in our BCSE sector, the voluntary community, faith and social enterprise sector, who really are the bridge between ourselves as organisations and communities themselves, as well as the other partners in the system. We need to be offering more personalised care. We need to be giving people access to information. Paul touched on 95% access to patient records. That's really important so that people can be making their own decisions, but also ensuring that we provide personalised care plans that meets people's needs. We are starting to learn that one size doesn't fit all. Our vaccination programmes are very tailored to be aware of the different ways that people access services. We know that we can't just put clinics on and people will come. There are groups that don't access healthcare in the same way. So we're working with faith leaders, with communities to put local clinics on and working with our partners across the system to do that. I think that's really important that as a health service, there's only so much local authorities can do to intervene and support people's health. We really want to get to a situation where people take a lot more responsibility for their own health and the environment around them can help them to do that. The NHS is very paternalistic, isn't it? So we really want to be able to give people the opportunity to improve their own health as an active partner, rather than just treating, and we need to help people to help themselves as well. So I think the current situation, it's very much focused on treatment. It's very reactive. We've got a high dependency on emergency care, particularly in secondary care, and that's largely where our resources are going now. If we are to move to more of a preventative health service, we need to understand what that means. So we're using the PHM data to help us to understand the health of the population. We're using it to forecast what our health care will look like over the next 5 to 10 years if we carry on in the current state. But we can also start to understand what would happen if we put interventions in that will prevent people from becoming ill. We've got some pretty poor health outcomes in Staffordshire and Stoke-on-Trent, particularly if you look at heart disease and the variants that go with that. And I'll give you an example of how we are focusing on the P's, and we've made a difference at scale to health outcomes, not just in the future, but being able to identify disease early and put treatments in place to keep people out of hospital. It doesn't take a long time to start turning that dial, although if we are really going to focus on healthy life expectancy, we're talking about a 10-year programme of work that we have to commit to. So I just wanted to give you the example of a programme as a system we've developed called BEAT. Originally, it was tailored to tackle heart failure, and it was led by our community partners in MPFD and Dr. Dargo Sachi, who's a cardiologist. And BEAT stands for, looks at my notes, breathlessness, exhaustion, ankle swelling, and time to test. And they were putting on a number of diagnostic events, let's call it that, in communities where people weren't coming into clinic and weren't accessing their general practice services and weren't picking up preventative measures early enough. It very much grew, and the huge opportunity came out of this to focus on all variations of heart disease, including atrial fibrillation, hypertension, heart failure. And the teams worked in Stoke-on-Trent, where we have got some of the worst outcomes in the whole of the county, to put on a number of events, to screen people, to revert them back into primary care and to get them on lipid treatments, for example. But they also started to use it as an opportunity to meet the integrated team across social care, across the voluntary sector and healthcare teams. So it was really an exercise in integrated working, actually. I think it's fair to say that the events which were held at Port Vale, working very much with our anchor organisations and Stoke City, we were amazed by the response. We were expecting a few hundred through the door. We actually screened 2,500 people at 3 events, and it was really successful. We identified scores of patients that we referred back into the primary care teams for more support, but we also picked up some pretty acute heart failures, which went straight back into the cardiology clinic the next day. So straight away, we were able to quantify the difference of that at scale in partnership model works, and we've actually got an ambition now to roll that out to 6,000 people in Staffordshire and Stoke-on-Trent using that community-based approach with our partners, the market model, where we're able to give lifestyle advice, information out to the people once they've been through the screening process. So I hope you find that's really positive. I mean, from a productivity perspective, these are things that are key to our ambition as an ICB. And actually, poor outcomes cost money. So the whole focus on prevention is better value for money going forward. And that's where we want to get to, as well as improving outcomes. If we just move on to the next slide, please. Giving you an example of at-scale prevention, this is where we are looking at targeting our resources and our both financial and our team resources into our localities. So Nikki talked about the portfolio, provider collaboratives and place, and this is very much about our places now. So across Staffordshire and Stoke-on-Trent, we've worked with our local authority and VCSE footprint to identify 12 localities. You will recognise 8 of them as our district and borough footprint, so they're very much about where people live. And in Stoke-on-Trent, it's the 4 locality areas built around wards. So Stoke-on-Trent North, Stoke Central, South West and South East. And the intention is to build an infrastructure for local decision making based on good information that helps them to prioritise where they focus their efforts, where they identify those common goals, and where they coalesce their resources to make improvements to people's health outcomes, to the experience that people have, and to access to services. So we're developing the locality footprint. What this means is, traditionally, it's largely been in the scope of public health teams and local authorities, but we feel as a health service, we've got a role to play to work with people and communities at that local level, very much supporting healthy neighbourhoods, building on the wider determinants of health to create those good environment for health. So, for example, we're working with warmer homes teams, where we are identifying areas of poor housing and linking the data to tell us where people are most at risk at hospital admission. So for people who've got heart disease, respiratory conditions, immobility, can we work with the local authority to target our resources to improve their homes? And we're starting to retrofit people's homes with doors now based on their health need rather than just where they live. We want to support healthy lifestyle choices, and we want to create joined up integrated teams that focus on targeted health in their areas and working with the wider sector, working with local communities to really build on those community assets that already exist. Health inequalities are unfair and unavoidable differences in people's health. You have to adopt a very targeted approach. One size doesn't fit all. It could be that within any of these areas, we can see some large differences in health. For example, we know that in some areas in Staffordshire, we've got a 9-year life expectancy difference between the most deprived and the least deprived in that area. We will need to target our resources, and Paul talks about clinical right sizing, where actually we need to put more resource into certain areas to make a dent into that health inequality. We are investing in our locality footprint, so we're developing something called an improvement framework, which will tie in our local authorities, districts and boroughs, alongside the VCSE, the voluntary sector and our primary care colleagues. So collectively they can target and maximise our resources at that local level. So we'll be launching the incentive frame, which we've called the LIFT because we have to have a 3-letter acronym in the NHS, from April next year with our colleagues in the locality areas. And if you go to the next slide, just finally from me, our VCSE are actually absolutely at the heart of everything that we do. We've got a huge, committed, capable workforce in the voluntary sector that we really want to work alongside and support the work that they do. We are working as part of the VCSE Alliance, which is support Staffordshire in the staff's footprints, and VAST in Stoke-on-Trent, and they're very much part of our strategic planning team, but also our delivery offer going forward. And I just wanted to highlight the work of the community health champions in Stoke, who are volunteers that help us to reach out into communities, and also the support Staffordshire offer, which is the community connectors, who help us to understand the needs of our communities and plan services differently. So I'll pause there, and I think, David, I'm handing back to you.
Thanks very much, Lynn. Thanks, Nikki, and thanks, Paul, for that section for the forward look. I'd just like to encourage the board to join me now on camera, and we're going to open it up for a public question and answer session. Before I do that, Tracy, can I just ask you if we've received questions in advance from members of the public that we will address first before I open the mic up, so to speak?
Okay, thank you, Chair. And we've received 2. So I'll start with the first one from Clara Gibbs. So from the Alzheimer's organisation. And Clara's asking, with the board's increased focus on health inequalities, are there plans to address the disparity between Staffordshire and Stoke-on-Trent regarding dementia diagnosis rates? Noting that Stoke-on-Trent currently has a rate of 94.8%, while Staffordshire's rate sits at 64.7%.
Thanks, Tracy. And Clara, thank you very much for the question. Paul, I'm going to hand that, I think, to you.
Yes, you are, David. Thank you. So, Clara, thank you very much. Very happy to take this offline with you if you want a little bit more detail, because we could go into quite a lot of detail about this. Just in essence, for the benefit of the rest of the board, the dementia diagnosis rate is calculated by comparing the actual number of recorded diagnoses of dementia to the estimated dementia prevalence in the population. So we're comparing as a numerator the actual diagnosis to the denominator, which is an estimated prevalence in the population. And I think that's quite important in terms of that. The simple answer to your question, Clara, is yes, we do want to address it. Just to put it into perspective, 94.8% in Stoke-on-Trent is absolutely excellent. It is really, really good, right up at the top of what is being achieved across the country. I think the ambition in the country is to get 2/3, so about 66.6%. So we're just about there in Staffordshire. One of the reasons why we do so well in Stoke-on-Trent in the north is that we've got dementia primary care nurses providing one-to-one support for GP practices. The PCNs there are running pre-diagnosis memory service overview clinics, etc. And I think also the fact that Stoke-on-Trent is a dense urban area may make it easier for people to access some of these things. So there's a number of reasons why things are much better in Stoke-on-Trent. What we now need to do is to work in Staffordshire to say, how do we emulate what has been done in Stoke-on-Trent? How do we improve that? How do we look to get those primary care nurses and so on? So the answer to your question is very simple. Yes, we're aware of the difference. We do want to make that difference. We want to have excellence across both of our areas. And if you want to know any more, I'm very happy to take it offline and talk through with you.
Thanks very much, Paul, and thanks, Paul, and Clara, thanks again for the question. Tracy.
Okay, the last question that we've had sent in to us is from Derek Hoey, and it says, following a significant number of reports of service failures in the area of non-urgent patient transport, the ICB undertook to monitor the performance of ERS Medical and associated companies. Can the board please provide an update on the results of this monitoring and action taken?
Thanks, Tracy. And if Derek's online, I'm not sure. Thanks, Derek, for the question. Who's going to take that?
I'll take that. If that's
sorry,
okay.
Phil.
Yeah, thanks, David. Okay, yeah, so absolutely right. During 23-24, we undertook a review of patient transport, and there was also a deep dive quality review as well. So we brought the recommendations of both of those together with a working group to formulate an action plan, so that the group's got reps from all across the system, so outpatients, renal, cancer, site ops, our integrated discharge teams. In practical terms, what have we done? Well, we've improved the oversight data, so we've got greater visibility of where there is service shortfalls, and then we've got regular meetings with the transport provider to review these. We've got training and education package for all of our staff to ensure they're confident in terms of the patient transport process. And as part of that, we've implemented a new booking portal, which supports more efficient and standardised processes in terms of transport booking. We've got improved patient-facing communications. I think there's a leaflet that's been produced to help there. And we have actually seen significant improvement in communication between EMED and the providers to enable proactive response to any challenges as they emerge. Outside of the action plan, the SCC team, System Control Centre, that I referenced earlier, work closely with all of our system partners and the transport provider on a daily basis to identify any issues and seek to resolve. We've also got a few separate streams of work. For example, a particular work stream underway to support concerns that we've had raised to us that renal patients face. And then from October this year, we've got some patient drop-in sessions will be in place for those renal patients to feed back directly to the transport provider and the ICB. So there's an awful lot of work going on in this space. Hopefully I've given a bit of a flavour there. Thank you.
Thanks very much, Phil. And Derek, thank you for the question. So Tracy, does that bring to a conclusion the questions we've received in advance?
It does, Chair. Yeah.
Yeah, so I'd like to invite anybody joining us this evening to put a question to the board. Ian, welcome. Ian, you might be on mute. Welcome to the meeting, Ian. Ask your question.
My apologies. I think given the stormy waters you've had to negotiate since the inception of the ICS ICB, I think there's been a huge amount of sterling work done, frankly. I think you should be proud of the work you've done. There's a hell of a lot to do, of course. Even to stand still would have been an achievement, but you've managed to chip away at electives, emergency, other forms of care, and your partnership working is a hell of a lot better than it's been previously. As you know, David, I've been campaigning for 20 odd years. Right, the question I've got, and it's an observation as well as a question, it covers fair and equitable services, health inequalities, and what was just mentioned, clinical right sizing. I think we'd agree that as a society, certainly in England, we're a sicker nation than we were even 20 years ago. So the workload on the NHS and the care system has increased quite substantially. I think inequalities, we know inequalities have increased substantially. That will affect health inequalities, and certainly those in the most deprived areas will be suffering the most. Now, there was a statistic, as you know, I'm a Stoke-on-Trent resident. It's the magnitude of health inequalities of Stoke that are really concerning. It's part and parcel, obviously, of the workload you have to address. There was one very stark statistic recently. Healthy life years for women in Stoke-on-Trent is the third worst in the British Isles. Only Blackpool and North Ayrshire, my relatives live in North Ayrshire, are worse. Staffordshire County Council will have areas equivalent to Stoke, but in general, healthy life years in Staffordshire County Council area are 6 years longer. So these are the kind of things you have to address. Now, I understand where you're coming from with, the integrated care partnership, but you also have to address what you're facing with electives and emergencies. The reality is, a patient taking an emergency ambulance to Queen's or Royal Wolverhampton or Good Hope or Warsaw is less likely to be stuck on the ambulance for long periods of time than they are if they have to go to UH&M. They're less likely to have 12-hour trolley waits. They're less likely to be discharged for delayed discharge. Now, how is that going to be addressed? And I accept, Bill, what you were saying, that there have been massive improvements in performance, massive, but that is still inequitable. Now, the southern patients, that needs to carry on improving. The northern patients, that needs to be dramatically improved. How is that going to be addressed?
Thanks very much, Ian, once again for a very clearly put question. I'm going to hand over to Paul. It's obviously a big question. We'll see where we get to with Paul's response. It may be that we may need to give a bit of detail offline just to make sure we've adequately covered the point.
Yeah, absolutely, David. And I can't possibly cover it in sort of 2-3 minutes and so on, Ian, as you know. Very happy if you want Phil and I to have a chat with you offline about it and so on. But you're absolutely right. The key dial that we have got to turn is that gap between the healthy life expectancy and life expectancy. We have to improve the healthy life expectancy of the population if we are to reduce the burden of care on our services. So we need to improve what we do around long-term conditions, because at the end of the day, that's the definition of healthy life expectancy, isn't it? The length of time that you are living without a significant long-term condition, and we need to improve that. We saw that come through in the Darcy report very strongly. So there's very much we've got we've got very much that direction of travel from the government around long-term conditions, prevention, really driving that forward. We've got to focus over the next few years, and that's what we're talking about right sizing, I think, is about focusing on dementia, focusing on diabetes, focusing on frailty, focusing on cardiovascular disease. How do we not necessarily prevent, but delay the onset of some of these long-term conditions, push that healthy life expectancy up by 2 to 3 years, and magically we'll start to see a reduction in the pressure on our services. So that's the key that we've got to do, whether you call it a left shift, a move towards prevention, getting upstream, whichever way you talk about it, that's where we've got to go, and that's the work we've got to do. And if we don't do that, we will continue to be reactive and we'll continue to struggle. So, David, that's my sort of best answer at the moment, is that's where we've got to go. I'm absolutely with Ian, and that's the way we'll take the pressure off our services.
Yeah, thanks, Paul. And Ian, I think Peter might just want to come in on this point as well. But again, just to say what Paul's described there is very much fully aligned with the 2 upper tier local authorities in terms of the strategy that's being driven forward. Peter, was it on that particular point that you wanted to come in?
Yeah, just very briefly, and thanks for the question, Ian. And I suppose it goes to the heart of what we're trying to achieve here. In equity terms, in inequalities terms. So there's 2 points for me. So the first one is that we've got a reality when it comes to urgent and emergency care service arrangements at the moment, particularly I'm referring to A&E and the major facilities within the system. And the truth is that Royal Stoke is a relative island, I think, in that we have, of course, Burton to one side, we've got the services in Shropshire to the other, Cheshire, etc. But it covers quite a vast space. So we've got a reality, I suppose, that we have that challenge naturally within the county. So the supply side of things, from the basic perspective of demand and supply, the supply side of things, we are challenged naturally in the north of Staffordshire, whereas if you go to the south of Staffordshire and of course beyond the borders, I would say that the Black Country is quite well blessed with the number of urgent and emergency care portals that they've got available. Now that's not a whinge, that's not to sort of be negative, that's to say, well, that's the reality at the moment that we've got to deal with, so let's deal with it. I think the supply side of things, which Paul's particularly referred to, is the area where we've got the immediate opportunity to be able to do better. So that's fundamentally ensuring that people don't have to attend A&E in the first place, and that can be as much the reactive side of stuff that various people on this call have alluded to, around making sure that we prevent falls, making sure that we utilise the other urgent and emergency care facilities better, but it's equally the stuff that's the proactive side of things and the preventative. And I think that's our massive opportunity. There may be a challenge of double running in that, because sometimes those service offers, new service offers, don't bear fruit immediately. They work downstream, and of course we've got the perpetual challenge of in-year balance financially, or get as close to balance as possible. But we need to think of solutions to manage that, because for me, the proactive and preventative side of things is the massive opportunity. But of course, we've got to get beyond talking about a number of the initiatives that we think will work, and implementing and doing that at scale and quickly. So I think for me, acknowledging the point around the capacity is constrained in certain parts of the system compared to other systems, we've got to just acknowledge that and move on, and really focus on that proactive and preventative side of things, because I fully acknowledge the point that you make, Ian.
Could I quickly have a second? Thank you, Peter. Thank you, Paul. Could I have a quickly, it's following on from this point.
Yeah, Ian, just on Ian, if on this point, yeah, I've just got Susan's waiting to ask a question as well. Okay. So please do follow on if it's on this point, and then I'll bring Susan in if I can.
What is your role? I mean, when we're talking about inequality, we're also talking about socio-economic inequalities. How do you see your role in alleviating those socio and economic policies? How do you perceive your role?
Very
Ian.
interesting.
Yeah, Peter.
Very interesting. So, of course, the Integrated Care Partnership is a key forum where that wider determinants of health are both debated and we direct action from. So the classic example in my mind that I always go to is warmer houses policy, that of course the local authorities have got, if you like, direct authority and responsibility for, but it fundamentally, you know, getting that right, having ensuring that people have got you know, good quality facilities to live in, as a minimum safe facilities to live in, has a massive positive impact on the number of people that present at A&E and through the healthcare system more generally. So we understand that link. That the challenge, of course, is continually ensuring that we break down the barriers between system partners, the various agencies that have direct links to those wider determinants, to make sure that we understand each other's perspectives, because I think for a long time that's just simply not been there, and somehow trying to create mechanisms that sort of deliver win-wins for us all, so that the local authority gain as a result of taking action that might actually historically have only directly benefited the NHS, and vice versa. Of course, we've all got opportunity in that regard. So ourselves as an anchor institution, you know, we in the NHS employ a heck of a lot of people in Staffordshire, and that brings a wider economic benefit. And so, you know, it goes both ways is what I'm saying. So for me, yes, it is tricky, but if we can find win-wins across partner agencies, and of course acknowledge what those key opportunities are, then there is benefit there. And I think the Integrated Care Partnership is a key mechanism to, because it's as much cultural, this is, I would say, Ian, as it is technical. And so the ICP is a key cultural forum that I don't know that we've ever had before really in the system, that enables all of those relevant partners to be in the room, debate, discuss and agree actions in that regard. So that was my starter for 10, back to what it was quite a sort of cerebral question.
Yeah. Paul, did you want to come in on that?
Just very, and I won't take long, David, just very, very quickly to say that as well as the ICP, we've got the Improving Population Health Programme Board. We've got local authorities on there, both the upper tiers and all of the lower tier local authorities are invited. 2 of the lower tier local authorities, their chief executives chair that board. So we've got really good local authority involvement there. Peter's absolutely right. We support through the inequalities budget that we've got. We support the Warmer Homes programme in Staffordshire. I can't remember the exact number of homes that we've helped support this year already. We're looking to roll that out into the sort of top hundreds and over 1,000 over the next year or two. And Peter's right that some of these things have an absolute clear impact on the health of the population and their health services utilisation and so on. So really important point, Ian. Thank you.
Yeah. Yeah, and just on that, nothing happens in a vacuum, and all assets, you know, Peter's point about the anchor institution, and Paul, the picture of the tree that he pulled together of all those assets working together to a common plan, is the only way we can deliver that. Ian, I'm just going to bring Susan in if I can, to make sure that she's had an opportunity to ask a question. Is that okay?
Yeah, go ahead. I'm sorry.
Yeah. Okay. Susan, welcome.
Thank you very much. When we last met last year, I raised an issue in dentistry and asked, was there any prospect of us following the example of Scotland and removing the juices and the sugars from particularly primary schools? I'd be interested to see if anything has been achieved, because this is one of the few things that will cost you nothing. And I'd like to demonstrate to you 2 examples. One is a little boy who is in a school for special needs school for children. And from 5 years of age, slowly, he would come to us, slowly, he would accept a checkup and then the application of fluoride paste. Fast forward to 9 years of age, he sat in the chair as usual. Mother beaming with a very proud smile, and the dentist could not believe what he saw. All 4 molar teeth were showing signs of decay. We questioned Mother. She's still doing as we advised. We asked her to go back to the school and ask what has changed. He had a new teacher who was feeding him sweeties to get him to do his work. So all day at school, he was being fed sweeties. The result was this child had to go for a general anaesthetic because we couldn't treat him in our dental surgery. We know that the greatest number of general anaesthetics are for dental decay. It's clogging our system. And I'm just asking if we can at least remove the sugars, the junk, the juices from our schools. One of our nurses went to collect her little boy from the primary school. He came out sucking an ice pop. He'd been charged 50p for it. She was horrified. Let's at least do something and follow Scotland's example. They've had tremendous results with it. I know the education regulations state, and I've had correspondence with the Secretary of State, Ministers of State, the onus or the judgment is on the head of the school. But surely we can do a directive and remove this stuff that's contributing to the horrendous dental decay that even the Prime Minister was horrified at. But we're going nowhere.
Okay, Susan, thank you for championing this issue. And I do recall you asking the question previously at one of our forums. I'm just going to push that, Paul, your way.
Yeah, just very quickly, David. So thank you very much for the question. Again, happy to chat to you offline if you want to. I think, as you'll be aware, this is part of the partnership work we've got to do, because obviously education and educational policy and any directives to schools sit with the local education authority rather than with the NHS. So this is something we'd need to work together on. I think we talked before about we've just had a Midlands dental plan produced, which has got prevention right at the heart of it. We're working on our local implementation plan alongside that, and we've got a health equity audit that's just been done by our local dental health, dental public health colleague, and very much showing that picture of decay in children and what we need to do about it. Oral health prevention sits with local authorities through the public health grant, the public health teams there, but it's something we need to work together on, and it's absolutely something we need to pick up. Part of our health inequalities work that we do around those health inequalities around dentistry, oral health. So we'll pick it up, we'll take it forward, and I'll talk to colleagues in local authorities about what the art of the possible is. I'll have a look at what the Scotland scheme is and how far they've been able to go. And I'll have a talk to local authority colleagues about how far they might be able to go in terms of that. So thank you.
And Paul, just on that for Susan, if Susan gives her contact details to you in the chat, can you just keep in touch with Susan in terms of the follow through of that? And Susan, thank you very much for attending tonight and asking your questions.
Thank you.
And Ian, thank you very much for attending as well and asking your question. So we are very nearly out of time, ladies and gentlemen. I'd just like to conclude by thanking everyone who's attended and participated in this evening's annual general meeting. This has been our second one. And what I want to do, and Ian touched on it kindly in the start of his question, I just want to put on record my thanks to all of our staff right across the NHS, social care, and our colleagues and partners in the third sector for everything that they are doing on a day-to-day basis. I'd also like to put on record as well my thanks to the team. It's great to be here as chairman and bask in the reflected glory of other people. But there's a lot of work going on. Ian referred to it. A lot of pressure out there. We don't get everything right. We've got a lot to do. I hope what we've demonstrated to you this evening is the energy and ambition that we have, looking forward particularly into 25/6, to do the best we can with the resources we've got for the people of Staffordshire and Stoke-on-Trent, and to shift the dial in the direction that many colleagues have talked about this evening, and particularly Peter at the start. So thank you very much. Annual report and annual report summary will be found, or can be found, on the ICB website under our publications and policies. So please visit the area, and hopefully in other roles you may have, you may wish to use elements of that in the meeting formats, etc., the information that you share. In the next few days, the recording of this meeting will be uploaded onto the ICB YouTube account and added to our website. And finally, can I just thank everybody who's joined us this evening and prioritised your time. It is very valuable to us that you continue to demonstrate that engagement and hopefully support for what we're trying to do on your behalf. So good night, everybody, and once again, thank you.
Thank you, David. Thank you all.